Hello everybody and welcome to our webinar today. It's session 2 of our chronic pain education. My name is Jenny Pearson. I'm an education officer for the Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the lands we walk, reside and work upon. We pay our respects to First Nations people and value the continued connection to culture, country, waterways and contributions made to the life of our vast region. I'm coming to you from Enewan land on the Northern Tablelands. We have 3 fantastic presenters for you today. Dr. Michelle Redford, who is a GP, Dr. Andrew Powell, who's a pain specialist, and we also have Dr. Kylie Bailey, who's a senior clinical psychologist. Don't forget, if you have any questions, please type them into the question box. We will be doing a Q&A session at the end, and there will be an evaluation that will pop up at the end of the webinar. If you could please fill that in, it's very quick. This webinar is being recorded and will be available in the Education Library on the PHN website. We do also have Sandra Fitzgerald here today from Health Pathways. So if you have any Health Pathways questions, please type them in. She's right here on hand to answer anything that you might need. All right, thank you everybody, and I'll hand over to you, Michelle.
Thanks, Jenny, and thanks for that acknowledgement of country. I would just like to acknowledge that I'm coming to you from the traditional lands of the Awabakal people and pay my respects to elders past, present and emerging. And as Jenny said, I'm a GP and I'm presenting in my role as a GP advisor to Hunter New England PHN, and part of that is within the Hunter New England Integrated Care Partnership. And as those of you who were with us last week will remember, we have already established some learning outcomes for these 2 webinars. So last week we talked about the biopsychosocial model and whole person approach to the management of chronic pain. And we also looked at some of the evidence around prescribing and deprescribing opioids and other medications in the management of chronic pain. So today, we're going to talk more about the interdisciplinary nature of our approach to chronic pain and understand the Medicare processes around case conferencing, both within primary care and case conferencing with pain specialists through HIPS. So I'm going to be focusing today on the case conferencing element, and then Kylie is going to talk more about an actual case study. So that's going to be really interesting. So just a bit of a refresher from last week that we're talking about the whole person approach to pain. And as you can see, this is complex. And in primary care and as a GP, I do feel like I need some support with managing some of these elements. And for me, that's where case conferencing comes in, to get that multidisciplinary approach to support the person who's experiencing chronic pain. This infographic is available on the HIPS website, where you'll find all sorts of other resources as well. And just to recap for the context, so we have identified within the partnership these 4 key areas that we want to work on around accessibility, affordability, awareness and activation for people living with long-term pain. And today we're going to be talking really about this better coordination between primary and tertiary care and case conferencing. So I'm going to talk about the why, the who, and the how of case conferencing. So why case conference? And again, relating this back to those 4 key aims. So one of the main things that people with chronic pain tell us is that they struggle with access to the teams and the individuals that they need to support them in managing their chronic pain. So particularly by using telehealth, we can get a team around that person and enable that person to access a team, in a more in an easier way, really. So instead of having to travel perhaps long distances, particularly if you're rural or remote, potentially you can be in your GP surgery and dialing in other health professionals on telehealth. It also potentially saves travel time and time for clinicians. And the idea is to be able to develop a shared plan around that person. Affordability. There are now Medicare rebates available for some allied health professionals under certain circumstances for case conferencing. So that has always been a bit of a barrier because in the past, allied health professionals weren't necessarily able to raise a Medicare rebate for case conferencing, but that has changed. Now, there is no compulsion to bulk bill these particular item numbers, and I will talk a bit more about that a bit later on. Awareness. So I think this case conference is a great opportunity to share expertise, but also to share the insights and particular knowledge that people have about the patient, and that obviously definitely includes the patient. And it's an opportunity for education, both for clinicians and for the patient as well. Activation is an interesting one. So my experience of case conferencing, or as my patients have said, is that it can be a really powerful experience to have your whole team around you, working with you to develop a plan based on your goals. And that is a way of helping with activation. It's also a way of helping to develop team working and interdisciplinary working for clinicians. So that's the idea of why we should case conference. And some more information here about some of the expected benefits of case conferencing around patient outcomes and around teamwork, with that core message really that the idea is to focus on outcomes that matter most to patients and to develop those relationships. You know, we work in silos still. General practice certainly can be a very lonely job in a room all day without very much communication with other healthcare professionals. And so certainly on a personal level, it can be a good opportunity to learn and also to build connection outside of the silo. And that has got to be good for patients. So who is eligible for case conferencing? So this is the patient eligibility criteria for Medicare rebates. Of course, you can do all sorts of things that don't have Medicare rebates, but if you want to raise a Medicare rebate, you have to fulfill the Medicare criteria, and they are complex. So services are available for people who either live in the community or are currently in an aged care facility. There are discharge case conferences, and there's some specific things about that, but I'm not really going to go into that today. So for our purposes, really, they're people who are already living in where they normally live, and they have to have at least one medical condition, and chronic pain would fulfill that criteria of being present for at least, has been or is likely to be present for at least 6 months, or have a terminal condition. And then this is where it starts to get, more detailed. So require ongoing care from a multidisciplinary case conference team, which includes a medical practitioner. So for these purposes, that's the GP, and at least 2 other members, each of whom provides a different kind of care or service to the patient and is not a family or carer of the patient. One of those can be another medical practitioner. So one of those can be a non-GP specialist, such as the pain specialist from the HIPS team, and one other person who would need to be an allied health professional or somebody providing a different kind of service. And the patient would have to consent to this process going on, but does not actually have to be present for a case conference. Now, personally, I would always prefer the patient to be present, because that's how we start to work on education and activation, which we miss that opportunity if they're not there. But they don't actually technically, for Medicare purposes, have to be present. And the minimum interval is 3 months, so you can't do it more frequently than 3 monthly. So with the current project, we're talking about 2 types of case conferences. One is with the specialist pain service, and that's as part of the pilot. So pilot practices will get support with that. The idea being that the person with chronic pain is in the GP surgery with the GP, and case conferencing with a allied health professional like a psychologist or a physiotherapist from HIPS, and also with the HIPS specialist doctor to try and develop a management plan. The other type of case conference, which can be done anyway, doesn't have to be done within the pilot, and is definitely underutilized if you look at the Medicare data, is doing case conferencing within primary care with other kind of private providers out in the community. So in this model, the GP and the person with chronic pain potentially be in the same room together, and the other allied health providers could also physically be present if that was required, or via telehealth. And some practices are doing this already. Certainly GPs and allied health providers often have some experience of doing this in workers' compensation work, but there is an opportunity there to maybe develop that further for people who are living with long-term conditions or chronic pain. Happy to take questions on all this at the end. So there are a few barriers and practicalities, and I suspect this is why case conferencing hasn't been taken up as a really high volume activity. So we need patient consent, and specifically we need patient financial consent. So we need to understand from all the providers involved whether they are able to bulk bill or whether they will be privately billing the patient and get consent for that. And that part of that, of course, will also be that the patient has to consent to assign their Medicare rebate if they're being bulk billed, and there's a whole process for that needs to be followed. Sending out invitations and setting an agenda and actually teeing people up to all be available at the same time is quite the process. You do need admin support for that. What we found in practice is that we don't necessarily record healthcare providers' email addresses, and so that's been one of the main learning points that we've had, that we do need their email addresses to be able to invite them through our video conferencing software. So we're now seeking those at the invitation stage. Timing, and that's finding a mutually available time, which is again quite a challenge. And for me, that normally involves the first session of a session, so the first appointment of a session, because I can guarantee I'll be running on time then and not keep people waiting. Video conferencing software, there is a whole load of information out there, particularly looking at this document from the government site that's Digital Health, which the link is the first one of those there. That's your guide to using online conferencing software. The preferred one tends to be Health Direct, but there are various ones available. You do need to be across the Medicare detail, which I will take you through. So just to recap, Medicare Case Conference provides multidisciplinary input to the person's care, can be provided face-to-face, by telephone, or by video link, or a combination. The 3 care providers have to be present for the whole of the case conference. You can't just dive in and out. And in terms of this project, we're looking at using case conferencing for seeking an opinion from the specialist HIPS team, or within a community-based setting with other providers to develop a management plan. You do have to make sure you meet all of the item descriptors, and there is a whole long list of them via that link on the note AN 0.49. Importantly, for eligible allied health practitioners to access a Medicare rebate for case conferencing, the patient must already have a GP chronic disease management plan in place. Now, so for GPs, that's item number 721 usually. They don't actually need to have a team care arrangement, but they do need to have already had that item number billed. The people who are involved don't necessarily need to be the people who are named on the GP management plan, although that would make sense, but they do have to have that in place. You cannot generally claim case conference item numbers with other, like attendance item numbers and things on the same day, but you can co-claim them with health assessments if you have met all of the item descriptors for both services. You certainly can't claim them with a chronic disease management item number on the same day. So it's fairly complex. And this is a slide just showing showing the list of allied health providers who have access to Medicare rebates for attending chronic disease management case conference services. And so a lot of these people would be really helpful in managing your person with chronic pain. So, mental health workers, physiotherapists, dietitians, exercise physiologists, a lot of people that can help us with these this whole person approach to pain. So that has opened up the possibility of more case conferencing, having those Medicare item numbers available. Other providers can also, so people who can't raise a Medicare rebate can also participate in case conferences, but there's no clear way of funding them other than they're doing it as part of their salaried service, or potentially they raise a private fee for the patient, which has an issue around accessibility. So home community services providers can also participate. It might be an important part of your case conference. Other allied health professionals, and certainly the patient's support person or carer. Now, an important point about practice nurses: a practice nurse cannot usually count as one of the minimum 3 team members unless they are acting independently of the GP and providing a distinct type of care. So that echoes the requirements for team care arrangements that probably most practices will be familiar with. So then, you're not normally going to be able to use your practice nurse as one of the 3 members of the team. So just be aware of that. And this is the current, and it's not current for much longer because it changes on the 1st of July. But these are the current rebates that are available for case conferencing. We are envisaging that the GP item numbers that are used will be the ones for organising and coordinating the case conference. And so those are the item numbers up there. As with most Medicare rebates, they are I suppose they're a higher per minute Medicare rebate for relatively shorter consultations. We're sort of thinking that most of these case conferences are going to fall into the 20 to 40 minutes realm, and hopefully closer to the 20 minutes than the 40 minutes, really focused discussion with the opportunity to then repeat a case conference, 3 to 6 months down the line. So as you can see, those are the rebates. And just the important reminder that for Medicare, you just got to be across it all. So you have to explain to the patient the nature of the case conference, record their agreement, record the day on which it was held and the times at which it started and ended, record the names of the participants, offer the patient and the patient's carer a summary of the conference and provide the summary to other team members, discuss the outcomes with the patient, and record all matters discussed and identified by the case conferencing team, and put a copy of that record in the patient's medical records. And then, you're done. So I think it is a really useful tool. I think it's underutilized. We do have the skill sets. We are now using more telehealth generally, both with patients and with others, and it's just another thing to add to your toolbox. I'm going to pass on now to Andrew just to talk about his experience at HIPS with case conferencing. Thanks, Andrew.
Thank you, Michelle, for that. So once again, my name's Andrew, one of the pain specialists with HIPS, just to talk a bit about our experience here with trying to communicate as best we can. The main issue I wanted to start with really is that we're endeavouring to try and get our communication better for GPs, and we really welcome feedback on how we can do that. We understand the limitations, but we do not truly, not living in the GP foot or shoes, I should say. So therefore, anything that we can provide GPs or even assist with communication, and we just want to get feedback so we can do a better job. Generally, I would say that most GPs are very busy, as you obviously acknowledge, and we don't want to interrupt your busy day and schedule. Often we find that most of our communication is just through letter, would be asynchronous versus a direct phone call or a conferencing phone call or telehealth. However, we recognise that as this new, I suppose, era post-COVID, that there's this greater opportunity to support each other in some of these difficult decision-making processes for patients undergoing, recovery from chronic pain. Just to go through what HIPS is endeavouring to do, and therefore highlight these things that you might be able to advise us on, is that patients get triaged here to HIPS from your referral. Once the referral has been received, we typically try to give an acknowledgement letter back with some outlining some management plans, which is just around the whole person approach. And it's just very broad, with the idea there to help broaden out the patients and management plan. The next thing after, as well as that GP advice letter, the patient is invited to attend the initial seminar, which is the introductory seminar, which we talked a bit about last week. This is a 1-hour seminar where the patient who's referred is welcome to HIPS and also introduced to a whole person approach to managing pain. Often when people do not engage well with our service, that's when they choose not to continue with the service, we then inform the GP again of what stage that patient is undertaking, which is a GP letter back to say that the patient has not or does not wish to engage, and then some further advice. From there, we are always open to receiving information or contacting from GPs to organise other strategies to engage the patient, which could be, as we're talking about today, case conferencing. And that can be done through GP organising with the pain service, the offices. Then we can then facilitate both a pain specialist and allied health professionals within the room discussing with the GP or patient. Often we recognise that GPs only have a limited time, as well as that the patients that they are most likely concerned about are the ones that are causing the most distress, I suppose, within themselves as well as the GP and the practice. And we recognise that this is an early development that we want to be part of, but we do need some feedback from GPs of how we can facilitate this as easily as possible and to help with the GP practice as well as particularly the patient. I think that's about it. I'll just hand over.
Hi, Kylie. I've just shared your screen, so can you see that pop up? I think you're on mute.
Is that better? And you can hear me okay?
Perfect. Yes.
All right. Are you able to show my slides, or would you like me to pull them up?
I can if you would like me to, or would you like to share them yourself?
If you've got them there, otherwise I'll do that for you.
Yep, no, I can bring them up. Just everyone give me a moment.
I do have it with me if you need me to do that, Jenny.
No, that's fine.
Okay. Just while we're looking for that, thank you. Just while we're looking for that, I think what I might do is just get started. Oh, thank you, Jenny. So I'm going to deliver a case presentation on a very complex pain patient. And throughout the case presentation, I'll be talking about how I've collaborated through case conferencing with a range of professionals, both allied health and with the GPs and other medical professionals. So next slide, please. So I'm Kylie Bailey, I'm from Innovate. I'm the Service Director, I'm a Senior Clinical Psychologist, and we are a psychology practice that also delivers individual and group pain treatment. Next slide, please. And I'll skip that one as well. So the patient is John, not his real name. He's a 44-year-old single man, recently single, and is overweight. At the time of referral and his first contact with us, he was 42 years old. He was in a relationship, but living independently from his partner. He has sustained a work injury where he's resulted in bilateral shoulder pain, and at the time of when we first met him, his pain severity was 8 out of 10. He had a diagnosis of subacromial bursitis. His procedures prior to seeing me included anaesthetic injections, steroid injections, and PRP. He had seen an orthopaedic surgeon who did not clear him for surgery, and that was because his pain had so sensitized that his nervous system was in overdrive, and the orthopaedic surgeon felt that that the procedure or the surgery would either have no impact on his pain or would make his pain worse. And he was also attending physiotherapy in his local area. So next slide, please. So for this presentation, I'm going to talk about it in 3 sections. As you can tell, I saw him from the age of 42 and he's now 44. And under workers' comp, psychologists can have up to 8 sessions. So I'm talking about the beginning as the first 8 sessions, the middle is the next 8 sessions, and I'm now in the beginning of the third 8 sessions. So at his assessment, he had recently seen a pain physician who had made some medication changes to try and help make him more comfortable. He had very, very low tolerances for sitting and standing. For sleeping, he had significant troubles where he could not lay down in a bed and he was sleeping in the lounge room on a recliner chair. He could only lift 2 kilograms and that was not repetitive, so it wasn't sustainable weight for him. He was not psychology minded, he was a tradie and had not had contact with any mental health professional before, and he was very biomedically focused and he was seeking a cure, and he also had significant psychological distress with extremely severe anxiety, depression and stress. Next slide, please. So in the beginning, the treatment plan was to develop a rapport, to engage him in therapy, to talk a bit about pain science, active versus passive pain management strategies, to also talk about the biopsychosocial model of pain and how we work within that and the benefits for him, and also to introduce psychological strategies to help manage pain. I also wanted to address his pain comorbidity, which was his mental health symptoms that were secondary to his chronic pain. And I used a motivational interviewing framework drawing on CBT, acceptance and commitment therapy, and dialectical behaviour therapy. So that was the plan. Next slide, please. This was the reality of that plan. At his first session, and it wasn't with me, it was with another psychologist in my team, he turned up drunk. He was intoxicated, he was confused, incoherent, teary, all over the place, very, very distressed, and had threats of aggression towards other people, but not towards the staff, and the threats were vague and more set in frustration and temper. So it became apparent that there was also some issues around alcohol and drinking with this patient, and you know, John had a lot going on for him. Next slide, please. So that was the presentation. And I'd like to note he didn't drive. He has no capacity to drive. He had a driver bring him to and from treatment. So he was then transferred to me, and we made an appointment, which he forgot on 3 occasions. And because where Innovate is located, we're in a building that is shared with 3 other businesses. So pain physiotherapy service, Hunter pain specialists, and a psychiatrist. So because I knew that John was seeing the pain physio, I went and case conferenced with the pain physio. And in that, we talked about treatment, and I also found out when his next appointment with them was. And so what I did was that I just lurked around the waiting room for him and personally introduced myself to him, and talked about, is psychology and attending treatment with me the right time for him. He reassured me he really wanted to work on his anxiety, and that he had so many other commitments around physiotherapy and multiple doctor's appointments. He found it really hard to keep up with everything. So we booked another appointment, and I said that would be the last one. If he didn't attend, we would just put treatment on pause. So I then case conferenced with the case manager, and we started teeing up our appointments with the case manager so that she could arrange a driver to turn up and pick him up and bring him to appointments with me. Next slide, please. So in the treatment, we looked at anxiety, and he wasn't able to leave the house. He was having panic attacks if he went into shopping centres or even the local service station. And he could only go in there if he knew the person who was working, and there was no other person in the service station. He had no routine. He would not talk about his alcohol use, and his appointment attendance was still haphazard, but it was improving. He had a failed attempt at returning to work in a different role, and he was still seeking a cure. So next slide, please. So it was quite bumpy, the first 1 to 8 sessions. And so by session 5, John had engaged in treatment and was regularly attending and didn't need the structure to be reminded of when to attend. Thiamine was introduced, and I'm not going to talk about this until a later slide because I think this has particular relevance to GPs. So at this stage, by the end of the first lot of sessions in the beginning, I collaborated with the initial psychologist who saw him, the pain physiotherapist twice, and also with the case manager. My thoughts were, there is so much comorbidity, how am I going to treat all of this, untangle all of this in a very limited treatment funding model? And he still wasn't ready to address his alcohol. Next slide, please. So in the middle, the next lot of 8 sessions, things started to shift. He really engaged with therapy. We worked on his anxiety, and his anxiety settled, and his extremely severe depression and suicidal ideation came to the forefront. And during this time, he had a 3-week inpatient stay in a mental health facility because of his mental health. I wasn't informed of what was happening, and it was only on day release that he actually contacted me to let me know what had happened and where he was. Drug and alcohol wise, he started to have detox admissions to Lakeview. He had longer periods between binge drinking episodes, which was great, so we had some shift there. And he attended a residential rehab for drug and alcohol, and he lasted 3 weeks with that because they could not accommodate his pain needs. Pain-wise, By the end of this set of 8 sessions, he had a reduction from severe to mild interference of pain in his daily life. He had an emerging confidence to self-manage his pain and not rely on medication, and he still unfortunately had significant pain cognitions that we needed to work on. Next slide, please. So I'm now circling back to the thiamine because it was in the middle part of this 1 to 8 where I was actively pursuing the thiamine being introduced because I've had lots of experience working in addiction, and I was very concerned about his confusion and ability to focus. So what I discovered was the pain physician had recommended thiamine, I had recommended thiamine, but nothing was happening. So I case conferenced with the GP, and in that case conference it was very, very informative, but we discovered it was his work cover doctor, and the work cover doctor said he did not act on any of the recommendations we had made, and that he left that to the GP, and he wasn't forwarding the information about the recommendation and the treatment reports to the GP, but none of us knew that there was another GP. So I then spoke to John, who identified he sees another 2 GPs. So I identified the primary one, and then I case conferenced with the primary GP and discovered that GP had received nothing, no reports, not from the pain specialist, not from the physio, and not from us. So I made sure he got all of our reports, and I contacted the other businesses and informed them of what was happening and to please send through the reports to the main GP. So now thiamine was introduced, and I see a lot better improvement in his cognitive functioning in appointments. I also case conference with the pain physician about the medium to long-term plan, and at this stage the pain physician recommended he do our intensive pain program. I wasn't convinced, but went through and made the offer and invited John into the pain program, and lo and behold, the pain physician was right and I was wrong. So to all of our surprise, he attended, including himself. I still continued to case conference with the pain physician. I also case conference with the orthopaedic surgeon, and that was a huge turning point in John's treatment and commitment to working very hard in our pain program. And I also case conferenced twice with the exercise physiologist around treatment. So next slide, please. So at the beginning of the year, he did our pain program. And for those of you that don't know it, it's 9 till 4, 3 days a week for 4 weeks, and it is intensive, and it is a multidisciplinary team with a pain physician, pain physiotherapist, and my psychology team, and a range of other allied health professionals, including OTs and pharmacists. So I'll just go to the next slide for time. So by the end of the outcomes, John had lost an awful amount of weight. He was moving more, his pain was reducing, his shoulders were so desensitized that you could now touch them, and instead of being like this, he was like that. And whenever he started to move into that position, he caught himself and would go back to that position. You could be around his shoulders without the look of, oh, I really want to punch you because you're too close to them. That had completely gone. All of his tolerances and capacity to lift weights increased. He increased his walking capacity and speed. He was going out to shopping centres. He was starting to plan holidays. He had increased his household activity with activities of daily living. There were some further medication changes, and the confidence was there to improve his pain outcomes. And so now the surgeon is very happy to perform surgery and feels that John is now a good candidate. So the next slide, please. This is I've seen him for 1 out of the current 8 sessions. I'm hoping that this is the last lot of treatment that John will need. So I'll be focusing on relapse prevention and helping him transition and increase his readiness to work, as well as thinking about how is he going to manage his pain when he's working, because that is a big obstacle to manoeuvre around. And with that, I'll be case conferencing a lot with the rehab provider to make sure that John is not set up to fail with job options and duties. So next slide, please. And if you can skip that one and move to the slide after that, that's just the list of all the people I collaborated with. With John, this was I asked him for his experience. He said at the beginning, he didn't know what to expect. He thought, no effing way am I doing this. This is a waste of time, and was avoidant. But after a while, he shifted into trusting, feeling safe with the treatments that we were delivering, having confidence in what we were doing, and having confidence in his own ability to manage his pain. He felt incredibly supported. He really liked going to one place to have all of his treatment. And I rang him last night to let him know that the presentation was on today. And the further advice he gave me was he wished he had gone through this earlier. And what he really liked, he feels 100% better. He feels like he can get stuff off his chest and feel heard. And what he really liked about the multidisciplinary case conferencing process was that we all talked together, we worked together, and that worked the best for him. So that's the end of my presentation and slides, and I hope that is really helpful for your practice and how case conferencing can fit in with you. So thank you, Jenny.
Thanks so much, Kylie. And I'm just going to share your screen again, Michelle, so that you can do Andrew's slides.
Have you got me there? Are we on?
Yep.
There we go.
If I can just get you to click on the display setting arrow. Yep, that's it. Thank you.
Sorry, are you reading these ones, Michelle, or do you want me to do these ones? Sorry.
Yeah, did you want to go through those, Laura? Is that okay?
Yeah, sure. Yep. So hi everyone, I'm Laura Bruhink, one of the pain physios at HIPS from last week. So our last slide is just on professional development opportunities for anyone who is interested in learning more, I guess, about pain. Some of these cover both acute and chronic pain, but more tend to be focused on chronic pain and its assessment and treatment. There is a lot of stuff out there. The first kind of 5 dot points are all multidisciplinary, so they're available to people from all different health profession backgrounds. They come from very small to very large. So the first one there, the Faculty of Pain Medicine online better pain management modules. I believe they're free, I think, for GPs, but are also available to lots of other health professionals, can be done in your own time. Then through to Sydney University and the University of South Australia have up to full master's level programs in pain. There's also plenty of regular conferences. I've put the Australian Pain Society one listed there. NOI is another group who have lots of very entertaining, I would say, short courses on pain science. The Pain Management Research Institute at Sydney also runs many short courses and webinars. And then there's a few health profession specific ones there as well. So any physios might be interested, there's pain courses through them. Same with nursing, there's the Australian College of Nursing. And for psychologists or counsellors, there's the emotional awareness and expression therapy is a newer professional development opportunity. So there's much out there from, like I said, from small to very big.
Thanks, Laura. That's great. And thank you so much, Kylie and Andrew as well for presenting. Reminder that you can pop questions in the question box, and because that's the sort of formal presentations done. So if people do have questions, then we're all here and happy to answer them. Kylie, it was fascinating the change in your patient that you've described there through that process. I wasn't quite sure, I might have missed it. How long, did that whole process take? How long was John's journey?
It's been approximately 18 months. It was an 18-month journey. It was, how will I describe, as a clinician, it was frustrating. It was a lot of hard work, and I really don't think without the case conferencing that my experience in delivering treatment with John, I don't think that would have improved. I think he was at great risk of just disappearing and slipping through the cracks and not having the treatment that he needed. I knew when I first met him, his pain management could be so much better than what it was. And he had been in already 2 years into the track or down the track of his treatment and still getting nowhere, which is quite frustrating. And there's a lot of barriers of why should I try? Tradies in particular tend not to see psychologists or be exposed to what we do. So there's a lot of stigma or misinformation or misunderstanding around what we do. And with chronic pain too, they're looking for medical options and not understanding what pain science is and what active pain management strategies are all about. So he had so much comorbidity. There were so many barriers. He has so many appointments. And to discover at the end of the 8 sessions that there were 3 GPs involved with only one knowing of one other GP, but still not passing that information on. And I think we're just so busy as health professionals that we forget about case conferencing, and we now have under Medicare as well as the compensation system, case conferencing is there. We can be paid for our time to collaborate. And I really don't think without that collaboration, he would have ended up in our pain program, because I thought he was just too disorganised. And he wouldn't have received the medications that he needed, because medication changes were being made, but they weren't being implemented because the wrong doctor had been informed. So have I answered that question? I tend to go off in a
Yes, you have. You answered it beautifully. Thank you, Kylie. I think it's fascinating, actually, isn't it? I think that would echo my own experience, which is, fairly limited probably compared to yours. But you don't actually know where that little missing piece of the puzzle is going to come from.
No.
And I think that would be a reflection that I've had about my experience of case conferencing, is that you have this view, from where you're sitting as one professional, but sometimes things come out in case conference that you just really weren't expecting, that then can be the opportunity to move people along. And sometimes that comes from the patient, with having that whole group around them, and sometimes it comes from just someone else holding the information, like in your case, where it was this whole other thing going on. And it just speaks to the silos, doesn't it? That we need to break down those silos. And
and I think case conference,
you can't capture it all in a letter.
Definitely not. And who has time to write a long letter to capture all of that, and who has time to read a long letter that captures all of that? Whereas with case conferencing, you can build that connection quite quickly. And I think what I really like from case conferencing with GPs, specialists, and other medical providers is you hear their different treatment aspects, So it broadens what treatment options are there. It gives you an idea of how things need to look for a patient in order for them to progress. And then I know how to help them. But it also speaks to, I have an hour or up to an hour with a patient where you may only have 15 minutes with a patient. So I have a lot more opportunity to spend more time to see what's going on and what the barriers are and how to work around them. And it's through that collaboration that better treatment planning happens and the patient feeling very supported. With John and with all my patients anyway, I'm very transparent about when I do want to case conference with someone and what the purpose of that is and what I'll be discussing, and do they have any concerns? Is there anything that they want me to be very sensitive about with them? What do I tell? What don't I tell? So, you know, if I'm case conferencing with a physiotherapist, my approach is more about what are the treatments you're doing? How can I blend that in with what I'm doing so I can help navigate around those barriers for exercising, for stretching? Because when you do have chronic pain and you do start moving and stretching, it does hurt for a bit. But knowing, is that the right treatment? Is it too much hurt and the approach is wrong? And do you need to see either a pain-oriented physiotherapist, or do you need to go and see someone who is pain-oriented? You know, they're not just focusing on rehab and strength and capacity, range of motion movement, because often that doesn't accommodate their pain, and it can cause a pain flare for days and sometimes a week. So then that disheartens the person of, well, none of this works. My only option is medicine and medication and surgery. So we want to broaden people's options and expand their chronic pain toolbox. And this is a great way of doing that. And so the case conferencing with the pain physician, the orthopedic surgeon, and the GP were massive turning points for me. And with the pain physio, it allowed me to use similar language. So when things were being spoken about, the patient wasn't feeling they're hearing different messages, because that can be confusing, because they can see an orthopedic surgeon, a neurosurgeon, a GP, and everybody's got a different opinion. And then they're confused of, well, what's the right pathway for me?
And in that context, of course, I'm assuming all kind of private providers, you know, outside of you know, the LHD and the hospital system. Have got a question for Laura from the audience, if that's all right, Laura. Thank you.
Yeah.
Can the allied health refer into HIPS, or does it have to be the GP?
It has to be a medical doctor and preferably the GP. Yep, for Medicare reasons can't accept referrals from allied health, but we also, from a clinical perspective, find that if the GP is on board, you know, they're really the centre, like, you know, of all that communication. If the GP is not on board with that referral, it doesn't usually go very far anyway. But I'd certainly encourage, you know, if you're an allied health professional and think my patient would benefit from a referral to HIPS, well, then maybe you're asking the patient to talk to their GP about that, or you're approaching the GP about that.
And there wouldn't necessarily be anything to prevent a community allied health professional from being involved if, you know, if there was a case conference set up with the patient, the GP, and the HIPS team, for example. You know, I think
that would be a great idea. It's probably even a better idea than, you know,
so
we can't see people as often necessarily, whereas if there's someone in the community involved, then I think that's a really great idea.
Yeah, so, you know, that's another potential thing that we maybe could explore through the pilot once that gets going at the pilot sites.
Yeah, and we definitely support, you know, as a pain physio, sometimes physios call here and just want some advice or want to talk about a patient, and we're very happy to do that. It's not, of course, something they can bill anyone for necessarily, but, you know, we're still happy to provide that service.
It's interesting, isn't it? We talked last week a bit about how often patients sort of were accepting of the service, you know, and what the barriers were. Kylie, how often do you find that people are amenable to case conferencing, that's something that people find acceptable? Is that...
I haven't had anyone. Yeah, I haven't had any professional that I have approached push back and not want to case conference. And you know, you tend to case conference more with these complex presentations, and that's why I have intentionally chose John, because we had an alcohol use disorder, we had severe anxiety, extremely severe anxiety, depression, stress, suicidal ideation, an inpatient stay, like someone who, how do you as a sole practitioner manage that? And the answer is you can't. You can only really manage that well and have a more stable patient in a quicker amount of time if you network and collaborate. So under work cover...
I'd be curious to know too, Kylie and Michelle, in that, like you mentioned with John, you feeling frustrated and things like that, if case conferencing has helped you as a health professional. I know it certainly has helped me. It can be emotionally challenging working with these patients, and I think case conferencing can be a way of seeing that, you know, I'm not the only person involved with this patient, that you don't have to take on all of their distress.
Certainly, and as a sole practitioner, you know, when you're in your room all day on your own, you know, yes, we see each other sometimes and we see the practice nurse and things, but it's actually really useful, you know, to share that, have that shared understanding, and yeah, I found it really helpful. I've only ever really done it in the, you know, very, you know, complex cases generally. Like, it generally is the most complex cases that we've got to case conferencing. Yeah, I think it should be more widely, you know, widely brought in, so that you're not always doing case conferencing with the very most tricky circumstances.
Yeah, look, I definitely agree with that, and I think with Medicare and that system, the onus is on the GP to, because no one will get paid if I organise it, but if the GP organises it, then, you know, we can have the GP, myself, and the physio, or whoever else is needed, and we can meet and we can case plan together and talk about what we're doing. So there's that more coherent continuity, better understanding by the patient of what's happening and why that's happening. And that was the other feedback from John. So if it's under Medicare, I can't encourage GPs enough to case conference. But if I'm seeing one of your patients and they're a bit tricky, expect a case conference with me.
So really encouraging GPs to get it organised and to develop their skills and confidence, I guess, in this area. And so that's a bit of a takeaway. I think we're pretty much out of time. I don't know if either of you have any other extra things to say. Otherwise, I'll probably hand over back to Jenny and see if she has any other things to wrap up.
I might just ask Sandra, if she's there, if she wanted to just show the health pathways slide.
Sure. Can you see me and have you shared my screen?
I'm just doing that now. We can see you.
Okay. Can you see the health pathways log on?
Yes, we can.
So the QR code is there if you want to just flash that at your camera at the QR code, and the username is, as always, HNE Health, and the password is pathways with each A replaced by a 1. Just want to quickly show you that we have this handy guide to MBS item numbers page, and if you're looking for all the Medicare information around case conferencing, you just scroll down here under C for case conference. We've got it all listed there. And the other thing I just wanted to show you is if you go on to the pain pathways, we've got a specialised adult pain management referral page, and under you'll find all of the information for referrals. Here organised by geographic region, and we have Kylie service in there too, and there's Kylie, and we've got the HIP service under public. So if you're looking for any of that information for the things I was discussing today, please go there. And of course, our chronic pain pathway that has been written by the team at HIPS has a lot of the information that's been discussed over today's webinar and last week's webinar. And thank you very much. I will leave with just that up for anyone who missed it.
Thank you, Sandra, and thanks everybody for presenting today. I always enjoy Kylie Bailey as a non-clinician. I think her presentations are great. And Michelle, thank you so much. We're meeting nearly every week for webinars lately, it seems. But as usual, you've done a fantastic job. And thank you so much to the HIPS team. Well, that's all for today. And don't forget to fill in the evaluation. Goodbye.